and I can see people still joining, so that's fantastic. So I'm Dave Gillespie. I'm a statistician and one of the directors based in the Centre for Trials Research in Cardiff University. And I'm also the academic lead for stakeholder engagement with Treialon Cymru. If you're new to these webinars, you might be wondering what Treialon Cymru is. So it's not new anymore. We used to call it an exciting new initiative. It's an exciting initiative funded by Health and Care Research Wales. And the idea is that it should be aiming to provide opportunities across the whole of Wales for people to engage with trials. So we aim to achieve that in 3 different ways. We've got a research development programme, and the aim behind this is increasing the number of large-scale trials that are led from Wales across areas of high priorities for our services. The associate membership programme, and this is to support people who are working in health and social care in Wales to be linked to CTUs, so not necessarily just the Centre for Trials Research, they could be linked to one of the other 2 CTUs in Wales, in Swansea and in Bangor. And the stakeholder engagement programme, and the idea behind this is to spread the message about trials across the whole of Wales, and we're trying to do that through these webinars, but also in-person events, and we're trying to hold these across different areas of Wales. So that might be something you already know, that might be new information to you. What I'm hoping we can do is pop a few links in the chat just about to give people opportunities to find out a little bit more about Treialon Cymru, but also to engage with us about some of these components. So if you're thinking or you're interested in leading a large-scale study in Wales, feel free to get in touch and we can support you with that. If you're interested in the associate membership programme, you can also apply for that through our links. And also our stakeholder engagement programme is constantly being updated. So if you want to find out what other events we have planned, feel free to check that out through the links as well. And if you've got any thoughts about other events we could be providing, please get in touch as well about that. So with that in mind, I'm going to hand over to our speakers today. So we have Rachel McNamara and Liz Randall from the Centre for Trials Research. And they'll be speaking about the design and conduct of trials in neurodevelopmental conditions and really focusing on progress, challenges and opportunities. So over to you two.
Thanks, Dave. Just going to share my slides. Bear with me a second. Can everybody see that okay? A slide with a green background.
That's fine. Yes, I can see it, Rachel.
Brilliant. Thank you. So yeah, welcome everyone, and thanks for coming along to this webinar. So I'm Rachel McNamara. I'm the director of the Brain Health and Mental Wellbeing Division within CTR, and Liz and I are going to be sort of sharing the presenting in this webinar. And Liz is a research fellow, and she is the lead within the division for our neurodevelopmental portfolio. So this is just a brief overview of what we're going to talk about. Really, we're going to sort of focus on how we came to be interested in this area of research, some of the lessons we've learned and the challenges, but also what the opportunities are, particularly around future research. Liz is going to talk about the work that we're currently doing in this area across Wales, but also beyond Wales in the rest of the UK. And further afield as well, and then hopefully we will have some time for questions at the end. So I thought it might be useful to start with a definition really of what we mean by neurodevelopmental conditions in this context. And I think for several reasons, really, I guess not everybody will be familiar with that term, but also I think even for people who are interested in and working in this area, it can mean lots of very different things. So this is really what we mean by that term. So we're talking about a group of conditions that affect brain function and that present during childhood, so during the developmental period, and that lead to difficulties with cognitive, social and/or emotional function. And these are lifelong conditions. So as I said, the onset is during the developmental period, but symptoms persist into adulthood, and in some cases, as is sort of increasingly recognised with autism and ADHD, may not be diagnosed until adulthood. So the list here is of the most common neurodevelopmental conditions, and these are in alphabetical order, not in order of prevalence or importance. And the ones I've highlighted in blue are the ones that we have kind of most experience of working with up until this point, really. So why is this such an important area, and why is there such a need for trials in neurodevelopmental conditions? So this is a population or populations who are at a significant risk of health inequalities for various reasons. Firstly, because lots of conditions co-occur in this population. So, for example, around a third of autistic adults will also have a learning disability. It's a group at risk of increased mental health problems. So approximately 80% of autistic adults will experience mental health difficulties at some point during their lives. And this is one that never fails to shock me, however often I come across it, is that there's a reduced life expectancy for adults with learning disabilities. So males die on average 22 years before the rest of the population, and females 26 years younger than the general population on average. And these are also populations or groups who are excluded from research, I think, for different reasons. And it may be that I think often historically we've tended to have a slightly paternalistic approach, particularly to conducting trials in neurodevelopmental conditions, where we might assume that there are capacity issues, for example, or that it may be unethical to randomise or to introduce particular interventions for some groups. But this not only applies to research and interventions that are sort of primarily targeting a particular neurodevelopmental condition, but also research more generally, particularly where they're assumed to be issues around capacity. And I think it's also being increasingly recognised by research funders in the UK that people with neurodevelopmental conditions have been really underserved by research in the past. And there's been an increase in sort of commission calls for specific populations in recent years. And also an acknowledgement from funders like NIHR, so that's the National Institute of Health and Care Research, that even with sort of more general calls around mental health, for example, that there is a need to focus on underserved groups, including those with neurodevelopmental conditions. And this is just a couple of examples from the last 12 months of specific calls that have gone out for research in these conditions. So, and there is a real need for evidence-based interventions in neurodevelopmental conditions. There's a couple of examples on this slide from systematic reviews that we've carried out sort of within the last 5 or 6 years, and these are examples from within intellectual disability or learning disability, as we more commonly refer to it in the UK. And this is around adults and children with severe or profound intellectual disabilities. And what we found was that particularly for around mental health, there's a real need for evidence-based interventions, but also that there's potentially an issue with measurement of outcomes for some groups as well, that we don't necessarily have the tools that we need in order to measure the impact of particular interventions. So as a result of that and the sort of this sort of early phase work that we have predominantly been been conducting in the last few years, because there isn't very much evidence on which to base sort of larger definitive evaluations. A lot of what we do is focused on feasibility. So I just wanted to kind of go over some of the key design considerations around that work, and the way in which we approach designing studies in this area. So I'm going to come back to these sort of 3 topics in a bit more detail, and they are things that you know, to some degree are applicable across all trials, particularly where we're talking about complex interventions in any population or in any setting, but there are sort of some specific nuances and things that we have learnt from working in this area in terms of neurodevelopmental conditions. So around how do you engage particularly underserved groups and settings where trials have not typically been conducted, because obviously without doing that effectively, you don't get good recruitment and retention of participants to trials. And how do we facilitate that? Lots of things to consider around developing and adapting interventions, which, as I said, are applicable for in all sorts of contexts, but there's some nuances, particularly in this population, and some specific things that we need to think about carefully in terms of outcomes, how we measure those, and then demonstrate impact. So thinking about stakeholder engagement particularly, and how we engage underserved groups, and what is kind of officially termed research naive settings. And I think that's a bit of a controversial term and one I don't particularly like. But by that, you know, we mean settings in which research or trials particularly are not commonly conducted. And really this is about how do we, carefully considering how we conduct meaningful patient and public involvement through all stages of research, and including, you know, very early on when thinking about the design of a particular study, but also thinking about the methods that we use to facilitate that, so to allow for direct input from the population that we're really interested in, which I think is particularly important when we're talking about neurodevelopmental conditions, and particularly again when thinking around issues around capacity. How do we really engage all stakeholders in the process as well, not just the participants, parents, carers, and those who may deliver or facilitate interventions and settings in which they're delivered. Thinking through obviously what the barriers and facilitators to research participation in this particular context might be as well. So that's about learning from learning as we go, really, I think, in terms of research that we've carried out in similar groups and similar settings, and we may do that sort of formally through process evaluations that we carry out alongside interventions, so interviews with participants and stakeholders. But something I think we could make more use of perhaps is reflecting on processes with members of research teams and research delivery teams to really learn from those experiences and build that into the design of future work. So thinking then about how we develop particular interventions in this population. So whether we're talking about adapting something that's been used in a different group, or whether we're sort of starting from scratch, really, there's things that we need to consider. And again, these are things that we would consider with any intervention, really, but there are some particular things to consider, or challenges in this group, because we need to think about, in terms of the population, obviously, levels of understanding, issues around capacity, but also, for example, whether there might be, for autistic children and adults, whether there are additional environmental or sensory considerations that we need to factor in. So thinking also about context, obviously, particularly where research is not, there isn't kind of a tradition of doing research or trials in this area. How likely are people to engage with an intervention? You know, what is their perception of how useful it's likely to be? How difficult is it to engage with? What are the levels of support that participants might need from parents or carers or elsewhere, for example, in order for them to participate in an intervention in a research study? We need to think very carefully about what levels of training are needed to enable staff to deliver an intervention, for example, and what the environmental or time constraints might be, and about how we expect an intervention to work in this context. So thinking then about outcomes and impact, and really thinking about what is important to all stakeholders, because I think sometimes we can make assumptions about who stakeholders might be, but in particular populations there may be more groups that we need to consider than there might otherwise be. So I guess I'm really thinking of so adults with learning disability, for example, we would need to be thinking about obviously participants, but potentially family carers as well as professional carers, and intervention delivery staff as well. So we really do need to think about who are the stakeholders, and also how well do their priorities align, because they may not necessarily have the same, hold the same outcomes to be important. So we need to think about what we do where those priorities don't align and how we manage that. Just a few things to note, particularly around measurement of outcomes as well. As I said, for some specific groups, existing measures may not be fit for purpose. There's probably been a bit of a tendency to rely on proxy measures rather than self-report, because that can be sort of more challenging to facilitate self-report for some groups, and can sort of add to the cost of research. But we do need to try and facilitate that as much as we possibly can, and think about how we balance that with using observational methods, for example, which is not something we could necessarily do for all participants in a large trial. So we need to think about how we can sort of balance that with other metrics. And how will we demonstrate impact of what we do? So that's sort of impact in the broadest sense, really. And obviously, if something works in terms of improving a particular outcome, so it's effective, then that's likely to have impact. If it's can be delivered without excessive cost, obviously that increases the likelihood that it will be impactful. But also it's about how feasible is it to scale that up and deliver that as part of usual practice or usual care. So what we're really trying to get to is this change in policy and practice, and we need to be thinking about that when we design research rather than just at the end when we have our results. We need to be thinking about building that in and being able to measure that systematically as we go. So I'm just going to sort of fairly briefly talk about some of the challenges that we've faced and the lessons we've learned. So possibly slightly unusually, I'm going to start off by talking about something that didn't work terribly well, and what we learned as a result of that. So apologies that this figure on the slide is quite small, but I don't think you really need to see the detail of that. So this is about, so this study, the example here is it's a pilot trial of it's a double-blind antipsychotic drug reduction study in adults with a learning disability, and it wasn't actually designed as a pilot study. It was designed as a definitive trial, and it was building on previous trial that had shown that antipsychotic use could be reduced in adults with a learning disability. without it having any negative impacts on behaviour. And I should just say that actually these are drugs that were being prescribed in this particular population to manage challenging behaviour rather than related to psychosis. But one of the issues with the earlier study was that because it wasn't blinded, that carers and clinicians were attributing all events to a reduction in medication, and people were being withdrawn from the study. So we thought if neither clinicians or participants or carers knew which arm of the study they were in, that we would be able to demonstrate we could safely reduce medication without any negative impacts. But as I said, this didn't. We weren't able to recruit to this study for a variety of reasons, and it taught us a lot about doing trials in this way. And I think some of the key things that came out of that were about how we conceptualize complexity within clinical trials, because on the face of it, this is a drug trial, so not a complex intervention, albeit we were reducing medication rather than introducing it. But actually we were sort of attempting to intervene on several different levels, so the sort of the combination of those contextual factors is really significant. And yeah, with hindsight, we'd underestimated that, really. So we do need to factor that in. So thinking about this, with more of a sort of systems approach and those different levels of intervention. And these are just a few quotes really to highlight some of those points and the things that we learned as part of this process, because we did some quite in-depth interviews with participants, carers and clinicians as part of this study to unpick where things hadn't worked. So there was some confusion around whose responsibility it was to give consent, but also there's a lack of confidence on the part of some carers to consent to something like this, and about whether that was the right thing for them to be doing. On the flip side of that, some carers felt that their views were not taken into account by clinicians. So some parents who had reservations about the use of these drugs and felt that they weren't necessarily being heard. And also some assumptions, and here's an example of a quote from a clinician: "Assumptions about autism and behaviours that challenge. They've made the assumption that any participants with a learning disability who also had a diagnosis of autism were more likely to demonstrate behaviours that challenge," but there wasn't any evidence of that. And as I said, the idea of doing this study in a blinded way was to remove some of that sort of bias around behaviour being attributed to reduction in medication, but actually that still happened. Even though people didn't know which arm of the trial participants were in, they still made assumptions on that basis. And there was also a bit of disparity between, in this example, family carers and paid carers in terms of the origins of changes in behaviour and what the best course of action would be. So, as I said, this sort of highlights some of the potential complexity in one group of individuals with a neurodevelopmental condition, but this has kind of led us to think about how we approach designing future trials, and this is something that Liz is working on as part of her PhD, is to looking at all of the frameworks and guidance that's already available for design and evaluation of complex interventions, and looking about sort of to develop some guidance around what else we might need to consider for neurodevelopmental conditions, and also more broadly for populations with cognitive impairment. So what are the really critical things that we should pay attention to? and how might be different in this group or groups. Okay, and I'm going to stop there, and I'm going to hand over to Liz, who's going to just give you a bit more detail about some of the work that we've recently completed and are currently working on. Liz, sorry, you're on mute.
Schoolboy error, thank you. I was just going to say I'm going to present in profile mode so I can read off a bigger screen, but it's nice to see so many people here. Yes, I'm just going to briefly describe some of the recent studies that we've been involved with at the CTR, and then go into describe a couple more studies that finished recently in a bit more detail as we've got the results of those. So as Rachel mentioned, we do some adaptation work as well as feasibility studies. And the first two that I'm going to just describe incorporate some adaptation and co-design work as well. So the first is Spirit. And this is a feasibility study looking at adaptation of an intervention for specific phobias in children with learning disabilities. So this study had two phases, and the first phase was to work with young people with learning disabilities, carers and family members, and also therapists to adapt an existing treatment for specific phobias. And then the second phase was to trial this treatment in adolescents with severe learning disability and autism as part of a feasibility study. And this study was funded by the NIHR, the Health Technology Assessment Programme, and it was being led by Kylie Gray at the University of Warwick. And Warwick are actually leading this, the running of the study with input from the CTR. Next is BEAMS, and similarly to Spirit, this study comprises an adaptation of an intervention and a feasibility study. So BEAMS is looking at behavioural interventions to treat anxiety in adults with autism and moderate to severe intellectual disability. This is a non-randomised study with a process evaluation as well. And again, this is an NIHR HTA funded study, and it's being led also by Warwick, but by Peter Langdon this time. So next we have three feasibility pilot studies. The first is Watch Me Play, and this is a feasibility trial of a remotely delivered intervention to promote mental health resilience for children aged up to 8 who are in contact with early years or children's services across the UK. Watch Me Play is an intervention developed as an aid for parent-child interaction by supporting caregivers' relationship and their interaction with their child. And we're looking to see if it's feasible to deliver this intervention online for families across the UK. So this this trial is funded by What Works for Children's Social Care, and this has recently merged with the Early Intervention Foundation to become Foundations. And the chief investigators for this study are Ailish Kennedy, based at the Tavistock and Portman in London, and also Vaso Totsikos at UCL in London as well. But the study is being fully coordinated and run by the CTR. And Watch Me Play is still open for recruitment at the minute, and it's due to end at the beginning of next year, in April next year. Next, we've got Zippy's Friends. So Zippy's Friends finished in January this year, and this is a feasibility study with that was randomised with an embedded process evaluation. And Zippy's Friends is a manualised school-based emotional literacy programme for children with intellectual disability, and it focuses mainly on a problem-solving approach to develop and improve children's emotional literacy. So this trial was funded by the NIHR again, and this was a public health research programme, and it's led by Bisa Stenford-Croser at University of Birmingham. So we had a bit of a split model with Zippy's Friends. So the trial manager for this study was based in Birmingham, but the rest of the trial team were here in the CTR. So that study has now finished, but we're just waiting for the results to be published. And then we've got VIG. So VIG is a randomised trial on video interaction guidance for families of children with a learning disability who've been referred to specialist mental health services. And VIG is an intervention where caregivers are guided by a practitioner to reflect on video clips or of interactions with their child to develop better relationships. And this is a feasibility study that's funded by RFPB, and it's led by Vaso Totsika again, with a team at UCL. So the CTR are just involved on an advisory basis with this study, and this study is still open to recruitment at the minute. So we're also delivering effectiveness trials. So EPATS is a cluster randomised controlled trial of a family support intervention for care and wellbeing. And this study follows on from an earlier feasibility trial that was run with the CTR. So EPATS is an intervention of it's an 8-session group programme delivered in non-NHS community settings to support parents with their own wellbeing and that of their child. So in the feasibility study, they recruited 74 families and they took part, and it demonstrated that the research design and methods were generally feasible with a few tweaks. So then this has gone forward to a much larger trial, and they're looking to recruit 458 families now across the UK. So this larger trial is in setup, and it's been funded by the NIHR Public Health Programme, and it's been led by Nick Gore at the University of Kent and being run by the CTR. Then we've got Schema. This is a trial of manualised interpersonal art psychotherapy for adults with learning disabilities who are inpatients in NHS secure care services. And this is a trial that's looking at effectiveness of interpersonal art psychotherapy, as well as longer-term changes in aggressive behaviour and distress. This intervention is delivered as 12 to 15 one-hour individual art psychotherapy sessions over a period of about 4.5 months. And currently it's open to recruitment, and we're looking to recruit 200 participants across a minimum of 10 sites throughout the UK. So this is an NIHR senior clinical lectureship that's been led by Simon Hackett at University of Newcastle. So now I'm just going to go into a bit more detail on a couple of studies that have been recently completed. So the first one is SANITA, and this is sensory integration therapy versus usual care for children with autism and sensory processing difficulties. And this was led by Rachel McNamara and Sue Delport as well. So this was Cardiff-based study, and the funder was NIHR, again, the Health Technology Assessment Programme. So SANITA was an effectiveness trial, and it was a 2-arm randomised controlled trial of sensory integration therapy versus usual care with an embedded process evaluation again. We were looking to recruit 138 children aged between 4 and 11 who were all in mainstream primary school education. So the children had to have a diagnosis of autism, or to be on the pathway to obtaining a diagnosis, and to have sensory processing difficulties as well, which we identified using a screening tool called the sensory processing measure. And we recruited across 4 health boards in South Wales and 2 areas in England as well. So that was Cornwall and Buckinghamshire. So the intervention is a manualised intervention of sensory integration therapy, and it was delivered in 26 one-hour sessions over a period of about 6 months. So this broke down as an intensive phase, which was 2 sessions a week for 10 weeks, and then a tapering phase, which is 2 sessions a month for 2 months, and then a phone call once a month for 2 months as well. And the comparator there was usual care. And the primary outcome we were looking at was irritability or agitation at 6 months. And we were also looking at a number of secondary outcome measures as well. So other problem behaviours and adaptive behaviours, socialisation, functional change, and carer stress and quality of life. So SANITA ran from January 2017 through to April 2021, and while recruitment was challenging, we did succeed in recruiting 138 parents along with their child to take part, and they were randomised on a 1-to-1 ratio to receive either the intervention or to continue with their usual care. The embedded process validation looked at how the intervention was delivered. So was it delivered as it should have been by all the therapists, which we regard as fidelity, and did each child receive the amount of therapy that we thought, or we'd hoped that they received? So that was the adherence. So in this case, we were expecting children to receive at least 13 out of a possible 20 intensive phase sessions. And we considered that to be a sufficient dose. And we also wanted to ensure that the children in the usual care arm weren't receiving SIT, so we called that contamination, and that no harm was being caused by the intervention. And we found that results of the process evaluation showed that all of these things were achieved. So there was good fidelity, there was good adherence, minimal contamination, and no adverse effects. However, when we looked at the main effects of the intervention on the primary outcome, of irritability or aggression, we didn't find a significant outcome either at 6 months or 12 months. And that's the same for the secondary outcome measures as well. And the economic evaluation also showed that the intervention was not cost effective compared to usual care. However, the qualitative interviews did show that the intervention was well received, and parents and therapists enjoyed taking part and saw a benefit to having taken part. But so overall, we can't say that this intervention demonstrated a benefit over usual care. And this is just a snippet of some of the infographic that we sent out to parents just to relay the results to them. And then finally, we've got STORM. So STORM is the Standing Up for Myself, which is a psychosocial group intervention for young people and adults with intellectual disability. The STORM programme aims to empower individuals with intellectual disability to challenge stigma, which is hoped that will potentially improve well-being and reduce inequalities. So a small pilot of STORM showed that it might be a good intervention to use on a community level. And the plan at the outset had been to carry out a feasibility study. However, this was just when the pandemic hit. So as the world was turning a bit more digital, the STORM team saw an opportunity to perhaps make STORM a bit more digital as well. So there was a bit of a redesign, and we focused on adapting STORM to make it suitable for digital delivery, and then piloted this version. So it was piloted with 4 groups that were already established in the community, and the outcomes focused on whether STORM could be delivered in this format and whether we could collect outcome data remotely as well, should we go on to another trial. So the results for STORM. 22 participants provided baseline data, then 1 person did drop out, and so that was 21 who received the intervention. The format of the session stayed mainly the same as the original face-to-face version, though delivery with the intervention was kept to 60 minutes as opposed to 90 minutes, and 30 minutes were used to allow for check-in and breaks, and just to use that time a bit more flexibly. The groups were slightly smaller than the face-to-face version, so the face-to-face would have 10 per group, and this online version was a maximum of 6 per group, and the number of videos used was reduced as well. Facilitators reported that delivery was feasible, and more than 90% of the key components of the intervention were delivered. And those who took part reported that the intervention and trial processes were acceptable, and some reported some subjective benefits to taking part as well. So examples being increased confidence, pride, and knowing how to deal with difficult situations. The pilot also showed that it was possible to collect outcome data remotely. So we had over 95% completeness on the outcome measures. And we also got a picture of what usual care, or usual practice rather, looks like for this population. So all in all, this was a successful adaptation and pilot of the STORM programme, and the team are looking at the next stages for digital STORM.
Thanks, Liz. So we just wanted to finish this session really with reflecting a bit on where we're up to and what we think the opportunities are for future research. So focused on a few things at the moment. So looking to build on the evidence that we have accumulated to date. So as you can see, we've already, from what Liz has presented, we started moving from some of the earlier phase feasibility work that we've done into applications for definitive trials, one of which is already underway. So with the example of EPATS, we've already started to recruit to that study, but we're also looking at what we can sort of learn more broadly across the portfolio in terms of principles and things that we can address you know, across all of the work that we do, and thinking again about what recommendations or guidance might be useful to inform future design and evaluation of trials, particularly in these populations, and whether that might be useful also to other researchers. with a continued focus very much on PPI and how we involve all stakeholders and how we do that from the very beginning of thinking about a study. So right from the design phase, so that whether that be co-design of interventions, but inclusion in all aspects of research. We're particularly focused on underserved groups, obviously, and not just in terms of access to trials related to underlying conditions, but actually access to all types of trials is something that we are increasingly interested in, and also with a focus on regions of Wales, particularly, and elsewhere in the UK that have been underserved by research. So how do we access participants in these populations from more sort of rural or remote communities where services themselves may be more difficult to access? Also been thinking increasingly about efficiency. So, and by that we mean, how do we minimise the burden of participating in research for participants, parents and carers, but also for services and staff who we might need to deliver particular interventions. Increasingly, we're focused on remote and electronic methods, something that's been accelerated obviously as a result of the pandemic, but we're reflecting on, how do we keep the best of those methods and take those forwards to make things, less burdensome for all stakeholders, but also more efficient and more economical. But also being mindful that those more remote methods may have unintended consequences in terms of including particular groups. So also keeping an eye on that as well. And thinking also more proactively about how to plan for impact. So how do we systematically measure and demonstrate that? And also, given that the populations we're interested in working with, thinking about how we disseminate the results of our research and engage with communities. So just a couple of examples there of some of the ways in which we're looking to present results more broadly to participants and stakeholders. So using things like infographics and animations. So there are also some other elements of Health and Care Research Wales infrastructure that have some opportunities for us in terms of the populations that we're interested in. So we're involved also in the Adult Social Care Research Centre, which has fairly recently been funded. And the idea is that the centre brings together expertise from across the university in adult social care research to allow us to develop research in this particular area, and the idea being that we sort of generate additional UK level research funding as part of that as well. But there's also some fairly new funding opportunities open to us now in Wales that we didn't previously have access to. So programme grants for applied research, which is one of the NIHR funding streams, we can now apply for from Wales, to be led from Wales. And there's also a new funding stream as part of NIHR just launched, which is the research programme for social care, which would be relevant to a lot of work that we do, because actually quite a lot of what we do is at that interface between health and social care. It isn't necessarily completely obvious which camp it falls into, if you like. So it has been historically difficult sometimes to get funding for that work. So these are really positive developments in that respect. Health and Care Research Wales have also recently relaunched all of their funding schemes as well, and in the sort of similar vein that the integrated funding scheme between health and social care is also quite helpful to us, given that the work that we're interested in and some of the personal awards that are now available from Health and Care Research Wales offer a really good opportunity to sort of develop researchers with an interest in this area as well. So in terms of some of the future work that we want to do, we would like to focus more on other aspects of neurodevelopment and neurodiversity. So, for example, ADHD, and obviously there's, I think, more generally greater recognition that neurodevelopmental conditions often co-occur, and that actually we should be looking at what are the similar challenges that might be encountered by individuals, and that's perhaps how we should define trial populations in future, rather than based on a single underlying condition. And yeah, that's us. So if anybody wants to talk about any of the work in more detail, then please do get in touch with either Liz or myself.
Thanks very much, both. Really, really interesting to see that. Obviously, I'm aware of some of those studies, but not all of them, but nice to see them sort of showcased as a package. We do have a little bit of time for questions, so if anybody has a question, please use the kind of raise hand function in Teams, and we can go through in order. Jeremy.
Yeah, thanks for a really interesting presentation. I suppose as someone who works a lot on kind of school-based kind of interventions, I was really kind of struck by the importance of what you said around the kind of the ways in which you might work with these kind of populations. And you mentioned also at the start the kind of the inequalities they face. So I suppose they're just reflecting how might we best kind of shape our kind of population level universal interventions to ensure that we don't increase those inequalities, and how might we bring some of the insights that you've brought here today around public involvement and co-production. So for instance, when we're developing healthy school environment interventions, we're not inadvertently doing things that exclude these populations or increase existing inequalities.
Yeah, I think that's a really important point, and that's one of the things that we're interested in sort of looking at more formally than perhaps we have done in the past, is to try and come up with some guidance around that for as you said, more population level interventions, because I think we have at this point been very focused on inclusion and accessibility of research that is targeted, for want of a better word, at people with a specific condition. But actually we're starting now to think about how do we facilitate inclusion and involvement in all types of research. So I suppose that's a very long-winded way of saying I don't quite have the answer yet, but hopefully we will do. But it's something that we need to sort of keep keep focused on and keep talking about, I think, as a community of trialists anyway.
That's great. Thanks again.
Okay, next up, Marie-Claire.
Oh, well, Ian's posed a question in the chat that I don't like. He obviously put his before I raised my hand. If you wanted to answer his first.
Sorry, Ian, I didn't see that. Would you like to ask your question, just to save my voice?
He's got some building. Oh, sorry.
Yeah, I've got some building work going on, so I'll do it really quickly. So, Rach and Liz, you're talking about sort of UK-wide collaborations and stuff. Is there any potential to work with groups in other countries, or is your work so tied to the sort of shape of the health service in the UK that it's not transferable, really?
Good question. I mean, there's definitely things that we would need to consider in terms of different contexts, but yeah, I mean, so not specific to the UK, and we are certainly thinking about ways in which we can make more international links. I mean, we did, not covered in the presentation, it's going back a few years now, we did do some work with other European countries around particular interventions in autistic young people. And we're also looking at how we might adapt mental health interventions with some colleagues in Australia and also Scandinavia. So we are looking at that, but we haven't kind of got anything particularly concrete yet. But yeah, we would like to do more internationally.
Sorry, trying to note take and field questions. Just before I come to Rebecca, Marie-Claire, did you want to ask your question still?
Oh, yes, please. Thank you. I was really interested in taking by what you said regarding the increasing, I suppose, trend towards co-production from within all trials. Obviously, I think co-production comes with difficulties for researchers anyway, compared to how they ordinarily work. But obviously for this type of group, it has an additional set of complexities. Have you looked at training that you could offer for researchers who hope to approach this group to be involved with their studies? You know, like considering the ideas of like Dr. Victoria Shepherd. She actually provides specific like worksheets and guidance for researchers, which I think might be helpful, because otherwise it can be quite onerous, the demands of working with people with additional learning needs, in addition to everything else you've got to do.
Yeah, I mean, I think that's a very good point. There's lots of additional considerations. I think, yeah, so there's some, the guidance that Vicky has developed is around, yeah, including participants with cognitive impairment more generally, and issues around capacity, which I think is really, you know, really applicable actually in this context. I mean, we haven't got to the point of sort of developing or providing training specifically, but we do work with our collaborators. So particularly in Warwick, actually, you have a lot of experience of co-production in populations with learning disability, because there are obviously lots of additional considerations, and actually you really need to think about the time and the cost of those activities is really important, and the support that allows individuals to make a meaningful contribution, and you know what the implications are for other individuals to support them to do that.
Can I just add, I was just thinking about Storm, and we did have quite a good co-production with Storm, and I think that was it showed that, you know, having that bit of time and space to be able to engage with people, it really kind of benefited the whole adaptation of that intervention, and how that was carried on through the rest of the study as well, so the rest of the pilot and the rest of the dissemination as well. So I think that was quite a good example of how we can engage and how that's done successfully.
Well, I suppose
Thanks.
it's sorry, I was just going to.
That's good.
So it's a really interesting point, and I think that might be something that we can pick up on in terms of, you know, we've been talking about developing guidance and frameworks around doing this kind of work, and that would be something that we would want to develop as part of that, but we're not there yet. Is that a fair comment, Liz?
Yeah, absolutely. Yeah.
So I'm just conscious of time, and I'm usually a really lousy chair, so I won't be that today. There's a hand up from Rebecca, so we'll go to her first, and then there's a comment in the chat as well.
Great, thank you very much. It was really interesting to hear about that array of trials. I was just interested in the one ones you presented, Liz. I think it was it the Sunita trial, that was looking at an intervention with autistic children, and that it was taking place in both in South Wales and over the border in England. And if you found that, was there any sort of significant differences in the delivery of that intervention across the two nations, and or with the effectiveness of the intervention? And then did that sort of have some impact on the trial design or the management of the trial design? And is that something that that you can then sort of create some guidelines if there was difficulties doing that with that particular group, I suppose, with that particular population group.
Yeah, so I think there weren't really differences in delivery of the intervention as such, because it was a manualised intervention. So we were looking at, was it delivered according to the manual? Did each therapist deliver the intervention according to fidelity measure as well? So I think, across the board, it was delivered pretty much the same, but there were differences in terms of the setups between the two countries. So we used private practices. We used a private practice in Cornwall, and it was a school as clinic in Buckinghamshire, as opposed to NHS clinics in South Wales. And I think just in terms of practicalities, we noticed a difference in terms of being able to see the children. And so that sometimes that was some of the things that created a bit of a barrier, was actually getting the children to receive the intervention, because more practical issues around availability and that sort of thing. So yeah, we didn't see differences in delivery of the intervention, but more practical issues maybe.
It didn't cause sort of too much of a headache then.
Too much of a what, sorry?
Too much of a headache in terms of the trial design or the management, or
no, not really. And I think just because, in terms of the management, that kind of complex intervention where you're relying on delivering a therapy, quite intensive therapy, was just always going to be quite difficult as well, just in terms of aligning everybody and getting everybody to intervention sessions on time and that sort of thing. But not really. I think there wasn't really too much of a difference between the two.
Okay, so that's maybe still more dependent on the local logistics rather than any differences between the two nations.
I'd say yes.
Yeah, great, thank you.
I'm afraid we're going to have to wrap up now. Just before we do, I just wanted to alert people to the chat, and there's a couple of posts from Richard Haggerty just about some feedback from today's webinar. So if you could click on that link and fill out some feedback for us, that'd be really, really helpful for planning future events like this. And I just want to thank again everybody for attending, but also for Rachel and Liz for delivering such an interesting webinar as well. So thank you, everybody.
Thanks, everyone.
Thanks all.